Here we go.
You're listening to the podcast between doctors and friends.
Welcome to another episode of this podcast. We have the usual suspects here, Dr. Ray and Dr. Foz, and a speaker, Auntie. And today we will be discussing schedules, doctor schedules that don't make sense. And speaking of that, before I move on, this episode we may have Dr. Ray may cut out early because of schedules.
She's got lives to save and not just sit here and chit chat with me.
I know. Can you imagine that? Last week you were on call and you shared that you were, tell us about your schedule. I know that doctors have different schedules. There's the surgical shifts, the clinic shift, the 7 on 7 off. Dr. Ray, let's start with you since you've got to go sooner. So what does this 24-hour shift mean?
Well, when I do a 24-hour shift, I do one of two ways. If I'm doing it to cover for my practice and the doctors that I work with, we take calls starting at 7 a.m. And then stopping at 7 a.m. the next day. But it's what's considered home call, meaning I don't have to be physically present in the hospital. So I just get all the phone calls from the hospital. And if there's a delivery that needs to be done, then I go into the hospital, or a patient that is having complications, and I'll go see the patient. But oftentimes during that 24 hours, it's home call, which just means mostly things that I can manage over the telephone. But if I do a 24-hour what we call in-house call, meaning that I need to be in the hospital, then I show up to the hospital at 7 a.m. Until the following 7 a.m. And then I'm physically present in the hospital to handle deliveries and any emergency that may arise at that time. So then I'm could be potentially working that full 24-hour shift.
Wow. And how do you, and you mentioned to me, kind of, outside of our recording, that you get home, you leave 7 a.m. the next day, you get home, and then you have to go to work at 9 a.m.? What the heck's that?
So it depends. Yeah. So it depends on which day I do the 24-hour in-house shift. So if I end up doing it like on a Saturday, obviously Sunday, then I don't need to go in. But this past weekend, I did the 24-hour shift on Sunday, and then I have my office starting at 9 a.m. So I'll finish at the hospital at 7 a.m. And sometimes I just go straight to the office because I'll go catch up on work. But sometimes I'll go home to see the dog, see my family, and shower, change, and then head to my office at 9 a.m. to see patients.
Holy cow. So you do a 24-hour shift, and then you do a clinic shift? Like, are you...
Yeah. Yeah. Well, usually on Mondays, I'll just work half day. So I'll just work till like 1 p.m. and then I'm off, and then I'll go home. So, but some days I work a full day. So it just depends. It changes from week to week, and it depends on what my call day is and whether or not I have a just half day after or full day after.
Wow.
But
I'm gonna make a note not to book an appointment on a Monday with my doctors.
Well, no, it's not every Sunday though. So like sometimes it's a Saturday, or sometimes it's just a Friday. But that's, with my schedule. So I don't like necessarily doing the Sundays. But I think because it was Super Bowl Sunday, they couldn't find anyone else. And so they texted me and asked me, and I didn't put two and two together that it was Super Bowl Sunday. I was like, oh, a Sunday. I was like, okay, yeah, I guess I'll go ahead and work it. And it wasn't until maybe about 3 or 4 days before I realized that, wait, Super Bowl Sunday is this weekend, and that's the weekend I'm doing my Sunday shift, and that's when I realized that I had made a mistake.
Wow. And so what do you do? What do you eat to prepare for that? I mean, do doctors like smoke cocaine? I don't know.
No,
Snort
absolutely
cocaine?
not. Absolutely not. No.
I'm kidding. I'm kidding to the
No,
listeners.
I mean, I just get, try and get enough sleep, and, you wake up and you go. I think doctors have been trained since medical school to, just wake up and go and get the work done, and to be resilient about it. So, you start the training in the latter part of medical school, and then your residency gets you trained for that as well. So I worked way harder and longer hours in residency. We would be up for 36 hours straight, taking care of patients and working. So it's not as bad as that time of my life. So you just get trained that way. You just get trained to work on less sleep, work on less calories, work on, not going to the bathroom often. You train your body to work that way.
Well, is it, and Dr. Foz, you could, help answer this question as well. Is it okay for patients to ask the doctor, like, how long into your shift are you in right now? Just to.
I don't think it occurs to anybody to ask that,
Okay.
And then, for example, if like Dr. Ray is the, on-call obstetrician gynecologist and you have a gynecologic emergency and it's 3:00 in the morning and she's been up since 7:00 in the morning, but she's on duty and is able to take care of you, like who else is going to do it? It's not like you have a whole bunch of choices, like that's what she's on call for.
And I honestly don't think the patients have any sympathy for the physician to ask that. I very, very rarely get asked anything about me being tired or overworked.
Oh, never. I'm always being accused of like, why didn't you do this or why didn't you do that when you've like already gone way above and beyond what anybody would do for a personal patient. So yeah, there's a lot of like, it can be sometimes quite a selfish relationship. And
Right.
the focus is supposed to be the patient. That's absolutely the case. But like, don't abuse us. We're not trying to hurt you. Kind of have a heart.
Right.
Wow, and I mean, your job is both, I guess, as an OB-GYN, it's physical if you're delivering babies, but then both of you, it's also mental. I mean, and then you have to have this customer service with a patient. That is wild. And I'm just learning that now.
The biggest problem with that yes, those are a lot of the list of things that must occur when you interact with a patient are there. But I think the biggest problem with that is you have to do it in a limited time frame. Like,
Yeah.
Even in a hospital setting, like it's not like you have all day to sit there and talk with them. You're like, well, you're having this problem and I have somebody who's about to deliver a baby. Oh, there's another one. Like, I mean, how, you can't, it's not like you have all the time in the world. When people are on call in the hospital, it's not like on TV where there's all this drama and you're having an affair with somebody in the broom closet or something. Like there's no time for that. There's no like, you're like running around and people are like dropping like flies. And I mean, it's not always simple.
Yeah. I mean,
you get pulled in a lot of different directions, and the patients don't understand or recognize that fact.
Wow. Auntie, you've got
so
a question?
I was just going to say, I see it's a systems problem. It's a systems and delivery system problem. Auntie's question?
Yeah, I just have to say I am certainly guilty of being one of the, patients or the general public, not really, the doctor's like, if the doctor got a lot of rest, it's the last thing on my mind. Like, I want to say I'm sorry for that, but then, hearing Dr. Ray's story and talking, when she was talking about how like medical school kind of prepared her for, these long hours and things like that, did it also prepare you that this would be like a thankless job, if you will?
No, not at all.
Oh.
I definitely think that the character of patients has changed dramatically over the last 30 years or so. I think before it was not as thankless a job. You definitely got thanks from patients. You felt appreciated. You felt like you did the work that was needed to be done, and
You
it
felt like you were
was
on a
well,
team. You
yeah,
were on
it
a
was
team.
well
Like you're
received.
teaming up with
Yeah.
people.
And, and sometimes, and not that this is important, but you would get maybe like a thank you card, maybe like a little thank you, you know, candies or cookies or some little kind of something that showed that somebody appreciated you doing, their surgery or delivering their baby. You would get, like little pictures of the babies. People would come back and be like, oh, this is the baby, like, giving it to you because they felt sort of appreciative and wanted you to be, have part of the experience with them. But that has definitely changed. Patients now are very entitled and very much like, you work for me. And this is what you need to do. And I read it on Google, and you need to do these things, and this is how it goes. And I saw a TikTok, and so you just need to do it. And that's it. So it's the character of the patients have changed.
That I would say that's, I mean, in the age of readily accessible information, whether or not it is accurate or not is certainly a confounding factor. And I also, like, thinking back on some of these questions, like, all residencies are brutal for all residents. There's not like, it's not like you get out of it without having to be sleep deprived beyond. And I think what happens is a lot of times you just focus on the training and what you need to do, and you don't necessarily realize like, hey, I'm not going to be 22 forever. And what I can do when I'm 22, 25, 27 on call overnight doing all these things may not fly when you're older than that. And then also when Dr. Ray and I both trained, like, we went to university, we went to medical school, we did our residencies, and we came out and practiced. Like, we weren't people who returned to our career paths, like, after having done something.
Mm-hmm.
So we were not, like, when we were in training, there was no kids involved. There was no husbands involved. There was no, like, there wasn't a mortgage that everybody was worried about, right? So it's all, how life just kind of
Yeah, I
piles
mean,
on.
how do you deal with, the life, phone calls?
You have to be good at juggling that, but I don't, just, and that's a whole other topic, but it's just very, what I think like looking back over all these years, like I don't feel that my nights on call like made me a better physician.
Mm-hmm.
I don't think they made me, and it is different for Dr. Ray, unfortunately, because babies will be born when babies will be born. And so there is no escape of the, the 24/7 kind of situation unless you share that with your partners, right?
Mm-hmm.
So, and that's why it's harder to be like a sole practitioner in a lot of ways. It's a little different for primary care, right? And but surgical stuff and obstetrics are definitely different. But I don't feel that any of my nights on call where I'm like, I'm getting hounded. I'm like dealing with patients, literally patients' lives. Like there's so much going on and my beeper's going off and like I just, running around and like this person, the ER is calling for this and then, whatever is happening and, and it's like chaos. I don't feel that any of those days have made me a better physician. I don't think I came out of it any tougher. I think what it would better is to definitely expose us to that because that's what you're going to have to do depending on, I mean, I don't do that stuff anymore. Like no thanks. But I don't think that made me overall a better physician. I think I would have rather have stayed in training for 6 months longer, do a little bit less call and have an opportunity for more didactics and better teaching and understanding and all those things, right? Because, after you've been on your feet for 18 hours, you're not really absorbing data well. It's not like I haven't eaten, I gotta pee, but there's no time. And it's like, and it's not like you're like, oh yeah, let's talk about the ins and outs of like pH management or something. You're like, I just don't care at this point. I just need to, what needs to happen? Okay, cool. I'll try to remember this later and maybe look it up or have a discussion with my attending or whatever. And then you just, it's just, I feel like the teaching doesn't have to, I don't know what it is like now. I've been told that it's less, but I don't really know if that's moved in the right direction either. And I don't know. I will refrain from commenting on that. But I just think that I could have been better educated if it wasn't such a chew me up and spit me out kind of situation.
Well, that's like, I know the schedules of flight attendants that do international, multi-continental flights. Your schedule is longer than them, and they get to change their PJs upstairs, and I think they get like a 4-hour, sleep break. And Dr.
It's different for every specialty, every particular situation, how much help you have. Like, just there's a million things that affect how that can be. In primary care, I do take call as well, but it's never in-house call. I don't do hospital work anymore. I'm outpatient only. I gave that up a long time ago, but I'm still on call, which means I still have to take call and triage things. And what's really frustrating for me is recently I was woken up in the middle of the night by a patient who had a concern that was somewhat alarming and not diagnosable by phone. There are a few things that you can tell, okay, this is definitely that, and then just do this and, whatever. But not everything is diagnosed by history. There are clinical diagnoses where they can tell you by history, and then there are other diagnoses that require an examination and or studies to determine, right? And so I gave this person advice, and it was basically, you probably should go to the emergency department because this is potentially very serious.
Uh-huh.
And this person was like, yeah, okay, yeah, that makes total sense. And then made an appointment with one of my partners the next day to be seen because this person was basically like, do you really think I need to go? And so the partner was like, yes, you need to go. And so the patient goes to the emergency room, and I don't know the outcome because it wasn't my long-term personal patient. But you woke me up at 2:00 in the morning to ask me that, and I was giving you legitimate medical advice, but you didn't believe me. So you went ahead and didn't go, and then wanted to get somebody else's opinion. Really?
Well, let's talk about that. When should people go to the ER and when should they not? Because you don't want to.
That's not an answerable situation.
Okay.
That's not one piece of advice. What I would say is, if anybody thinks they're seriously ill, you should go to the nursing home.
Well, I think if you call the doctor and the doctor says go to the ER, then you should go to the ER.
Okay.
That for sure.
Yeah.
I've had many patients call me. I've had many patients call me, and they resist going to the emergency room so much. So they'll tell me their situation, and I'll say, that sounds like it could be something, more serious, something I can't really help over the phone. We need to get some more information, so you should go to the emergency room. Well, what about this? And I said, yeah, but you should still go to the emergency room. Well, do I need to go now? I have to say it 5 times before they finally will hear me or listen. And still, sometimes they don't end up going to the emergency room. So if
we're not doing it. We're not doing it for our comfort. I'm really gonna if I don't think you need to go, I'll tell you. And this person, if I thought it was something that we could just handle in the morning, I would have had them booked for a morning appointment, and then we can address it, urgently as an outpatient. But
okay, so guide us, when
take our advice. How about that? That's
when to go to urgent care versus when to go to ER versus when to call 911.
It's also not a clearly there isn't one piece of advice that would tell you that. But if you think it's life-threatening, you should go to the emergency room. If you think oh, I got a little cut on my finger and I don't know if I should have some stitches or if I should just bandage it, that should go to urgent care.
Okay.
Or that can go to, you can also go to the emergency room. I'm not trying to dissuade anybody from going to the ER, but you can go to the emergency room, but you may be able, so urgent care is generally considered a lower acuity care. This also is extremely variable. as somebody who's worked a fair amount of urgent care in my life, urgent cares can be quite basic. It's me and my stethoscope and a pregnancy test and a strep test, and that's it. I can
Okay.
order labs, I can order x-rays, but they'll be handled as an outpatient, just like if you were to see me in the office. I've worked in urgent cares that are essentially one step below the emergency room where I can get labs and I can get imaging and I can get diagnostics right now, you know. So like I can order that CT scan and we'll have a result in 2 hours or something like that.
Okay.
So
Um,
that's why it depends on what's available and you can't really know these things,
yeah.
right? So it is really hard that's a hard thing to give people advice on. And so that's why I would recommend talking to your local physician, like your local primary care physician, be like, yo, I've been having this. Okay, you need to be seen, but you can't see me. So should I go to urgent care or emergency room? And then don't forget, with a lot of insurances, you also have a nurse advice line. So you
Okay.
can often take advantage of that and contact the nurse. There's like a 24-hour, like, you know, kind of like a triage line for a lot of insurance policies. Not everyone, but a lot of them do. And then also part of that, I think one of the reluctance of going to emergency room as an urgent care isn't so much like, should I go? It's the costs associated with it, right? If you have a higher
Okay.
deductible plan or whatever the situation is, like where are you in terms of cost? And that's also like a terrifying thing because I wonder how many people whose lives have been lost or have been disabled or have had a much worse like recovery period of things that have been dealt with sooner, like allowing a medical professional to triage you. And so that's what happens when you go to the ER is like there's generally like a nurse who's trained to triage people. Like, hey, this person is bleeding all over the place. We need to get a doctor involved right now. Or this child is looking blue and like they're going to pass out in a second. Something is wrong. I need the doctors here right now. Versus, well, I twisted my knee when I was playing soccer today. Now I'm having a hard time walking. Okay, you're fine. Everything looks good. Okay, sit down. We'll be with you as soon as we have dealt with all the emergent stuff in front of you. And so that's when patients get stuck with like a longer wait. So the triage in the emergency room and in urgent care has not a lot to do with when you arrived. I mean, there's
Okay.
always a little bit of that.
I'll give you a scenario, and again, you know, for those listening, and I know for myself, this is just generic. Okay, so, I think I broke my ankle at 11 p.m.
Hmm.
Do I go to the ER?
Well, a
Do I
lot of
go to the
urgent cares
urgent care,
a
or do
lot
I
of
wait
urgent
it
cares
out?
they won't be open.
Uh
They
huh.
won't be open.
Yeah.
So
Okay.
like, you know, that might be something you might want to, that's, you know, does my leg look like it's going to fall off? You
Hmm.
know, if it's something like, I mean, certainly anything could be very, very serious. Like, I mean, if your foot's flapping in the wind and you have no control over it because both ankle bones, like both, you know, main lower extremity bones are broken, you should probably,
Go to the ER,
I
right?
just saw this grossed out
And
face.
okay, and then
But
let's
I mean, you should
say,
probably go to the ER. But like, if it's
okay,
like, hey, I twisted my ankle and it's kind of swollen, I don't know if I should. I don't think it's broke, but I don't know what to do at this point. Like, you can also, I'll see if an urgent care could see me in the morning or call my primary's office. Or, I mean,
okay,
it is hard because, I mean, that's the advantage that you have, right, of us, is you can contact any one of us at any time and we'll be able to tell you what to do. But
yeah,
there is a little bit of, this is what I call the kind of like, I call it mom medicine. It's like you
a
kind of
bit
have to
deep.
know how serious it is. It's like common sense. Well, it's just using common sense. You know what I
Okay,
mean? It's like if somebody falls and scrapes their knee, and you know, 6-year-old scratches their knee and they're fine and they're running around playing. Well, clean it off and take care of the wound just like any mom would. But I don't think you have to run to your doctor for that. You
okay,
know, bodies will get sick and bodies will cough and people will get fevers and people will twist ankles or whatever. And it's not, you know,
okay,
it's
okay.
not the end of the world.
Another scenario. Um, you hurt yourself and you're on the second floor of a house, and
I know what this is about.
you know it's pretty bad, and everyone says go to the ER, but you're upstairs, you can't go down. Typically,
That's when
again,
you
we're
call
talking general. I'm giving you like we're
right.
trying to
So
call
if
you up, like
so that's sometimes with the role of emergency medical services, right? So 911 or wherever you live, EMS, because they can help transport you if you're not able to be transported.
there you go. Okay, so 11 o'clock p.m. and I broke a glass in the kitchen and I stepped on it.
Mm. Are you bleeding
911,
all over the place?
ER, uh-huh.
Are you bleeding all over the place?
Let's
Like,
say,
is it bleeding and bleeding and
not
bleeding? It just won't
really,
stop?
not really, but I don't know if, because, people start to kind of come up with like, I may have cut, I don't know, like,
Yeah. Well, I mean, you can do damage like that. I mean, but if it doesn't seem like it's serious and you might have some glass lodged, you certainly can think about, well, maybe I'll wait till the morning and see urgent care or my primary, or go to
mhm,
the emergency room. Like, they're
mhm.
not going to not want to see you. People in the emergency room want to take care of you and make sure you're okay.
Okay. I'm just gonna give you scenarios. Something's wrong. You should go to the ER, but you don't have health insurance. What should you do?
Oh,
Go to the
see,
ER.
yeah, see, a
Okay.
lot of this depends on where you live.
Okay.
I will say that, but where, because a lot of counties and cities have much better safety nets than others.
Okay.
Um, I think it depends on your level of, you know, your level of concern. A lot of places, unfortunately, a lot of places will not see you if, like, in the outpatient setting. So you're like, look, I don't have insurance, but I just want to see a endocrinologist, let's say, because
Okay.
they're
What is an
whatever.
endocrinologist for
Okay,
our
maybe that was
listeners?
a bad example. An endocrinologist is a gland specialist. They deal with like diabetes and glandular and hormonal problems. So if somebody has like a serious thyroid condition, that would be the endocrinologist. The endocrinologist often manages diabetes, particularly more complex diabetes cases that primary care will assist in, but maybe not primarily manage. And so what happens is a lot of patients will be like, I used to work in a place where we had a lot of uninsured patients, and they would come in and, I'm like, well, you really need to see this specialist, endocrinology, whatever, and I don't have any resources for you, so I'm going to have to refer you to the county system, which is a whole other complicated thing. But they're like, well, I don't want to do that. I don't like the county or whatever, so can you just refer me? Who's your preferred endocrinologist or whatever ologist, and I'll just pay for it out of pocket. Well, the problem with that is a lot of specialists actually don't want to see people cash pay. I know how that sounds, but because there's so much more that's
I'm
involved,
sorry. Say it again. They don't want cash pay. Okay. Sorry.
a lot of them won't
Okay.
because there's so much involved, right? It's like, let's say somebody has some strange hormonal problem that needs extensive evaluations, right? You need studies, you need special hormone tests that are like, you have to take this hormone and then overnight, and then we're going to then check your hormones every 3 hours. Well, I mean, like, there's a lot of stuff. There are these like elaborate protocols to make the diagnoses of some more, less common illnesses,
Mhm.
and those things are complex, like, and so they're not going to, or if you have like, okay, I'm bleeding, I'm rectal bleeding, it's not emergent, but I don't know if it's cancer and I don't know if it's hemorrhoids, and so I need a colonoscopy. Okay, well, but I don't have insurance. Okay, I can refer you to the county. Well, I don't want to go there. Just send me to a gastroenterologist. I'll be happy to pay for it. Well, if the gastroenterologist is not going to be able to do a whole lot if you need a colonoscopy. So it gets into these things where patients may not be able to afford some of the studies that are associated with it, because it's not like it's just an opinion on everything that I've already done for them. Does that make sense? There are things
Mhm.
that are outside of the scope of primary care that I cannot do. They are outside of what we should be doing or able to do. And so that's where the specialist has to step in. And then it becomes a whole like, well, how much is that going to cost? And so I've talked to a lot of the specialists that I've worked with, and they're just like, it's kind of not worth the trouble. As much as they want to help, it ends up being more complicated.
Hmm. Now,
And so
uh,
there's safety systems for that though. There's county clinics and facilities. Like, there's usually in more developed, like, I don't know about working in very rural parts of this country, right? Because
okay.
I think that access is a huge issue in those areas. But in like more urban or suburban places, generally there'll be systems in place for people who are underserved and can get into county systems and all those things. Like the two main counties that I've worked and trained and practiced in have like had really robust county systems, and I thought, and it's funny because it's just, wow, there's really great services available here. The hospitals are quite nice and the specialists are excellent. And so there's, it's not second class like treatment.
Okay.
It's more frustrating in some ways because you have to now you have to wait in line and you might have to be around people who may be not in the same social economic class that you may be in. And so it's definitely more, kind of open to all comers situation, but that's sometimes
Well,
the care there is quite.
well let me bring it back to schedules. Is 7 a.m., 7 p.m. the typical schedule in like hospital ERs, or every hospital has a different shift schedule?
I think most of
There's
them
a lot of
start either, they
variation.
go, 7 a.m. to 7 p.m. or 8 a.m. to 8 p.m. Those are usually the times because nursing, they coordinated with nursing shifts, and those are about the time nursing shifts change over as well.
Wow, that's really good to know. So if I have to go to ER to go towards those early shifts, so my doctor or my
Well,
nurse.
the ER in the morning and the ER in the middle of the night are kind of different experiences. There's a
Really?
hand up.
Okay, go ahead, JJ.
Who's JJ? Somewhat topic adjacent. Is it true that doctors make the worst patients?
Probably. I think so. I think
You know,
because they self-diagnose a lot, and so I think that is probably why they get that
I
reputation.
have not had that experience. I have had physician patients that were quite, they were pretty okay. But, it's not like I've had 400,000 of them. I've had 10.
So
That's not really a huge population to pull for me to have a strong opinion on.
okay, so for the follow up question with that, Dr. Ray, you're a mom. Has there been a time you're at work and one of your kids, Mom, I think I broke my elbow. You're like, go to the ER, or I'll see you. Any situations like that?
Thankfully for me, no, that has not happened. But I've had situations where I think just once where I was on my way home and I had a child cut themselves, and I was just like, wait till I get home and then I'll take a look at it. But luckily, yeah, I mean, if you're at work like any other job and your child calls and says that they've had some sort of accident or injury, then yeah, the most likely and sane thing to do is tell them, have some adult drive them to the ER, and then you meet them there.
Mm-hmm. Auntie, you've got a question.
Well, yes. Well, one, I have a comment and then a question. So the comment is first, thank you so much, Dr. Foz, because in my now almost 40 years of life, I now finally understand the difference between the emergency room and the urgent care. Because the only I didn't know that. I thought the only difference was the office hours and the copays. But
sometimes there is a fine line. I'm going to tell you. When you say urgent care, the range is quite broad, but you're welcome.
All right.
Yeah. And my question is, so after hearing your stories about scheduling, especially someone like an OBGYN who's always on call at any time of the day, say for example, a regular Joe like me who I want to go in for my maybe early morning appointment or afternoon appointment, would it be appropriate to bring the doctor hey, I got you this muffin, I know you probably haven't eaten yet, or would you appreciate that, or would you kind of think that's inappropriate?
I would love
really
it.
Sweet.
Yeah,
I
would love
adorable.
it. And any
Good to
act
know.
of kindness.
Good question, Auntie.
I think anyone appreciates any act of kindness, so 100% would appreciate it.
Good to know. Okay.
I have to say something about that. I really do. I'm going to sound so mean. I don't mean to. Maybe I am mean. So, I mean, I think that's really kind of people, even like the idea, even if you just picked up a rock off the street and brought it into me and just said, hey, this is a really pretty rock and I thought of you, so I thought you might like that. Like that would bring me near tears, right? Just because
I got you a bug. I got
yeah,
you a roly-poly.
I found this gopher snake in the yard. I thought you might like it. I mean, it's just like, it's the idea that like, it's like somebody thought kindly of me and appreciated what I did, and that would be enough. It's not what it is. It's literally the thought. And then you wouldn't even put more effort in to actually get that rock. Like, so I dig it, right? However,
Here we go. Here we go.
Once again, where I had patients with all sorts of serious problems and not a lot of resources. And it was very sobering. And I've spent a good chunk of my career doing that. Okay. And so we had this really nice person bring in stuff, and was very kind and, tried to be really helpful. But like, I wouldn't eat anything this person made. I would eat it if they brought me something sealed.
So treat it like Halloween candies. You know?
Yes.
Okay, I get it.
Isn't that terrible? So there are some patients where that's absolutely not, like, you know them well. You know, like, that was really nice. But I'm not going to eat every homemade treat that somebody gives me. Isn't that mean? I sound so mean.
No, we have someone in the audience that, you know, ask, what if the food was made with special butter?
Shut up, Beasley.
But I just, oh no. And so I just, Halloween candy. That's a great way to think of it.
But Dr. Ray will eat
I
it.
would eat it. I would eat it. I eat everything, and my staff eats everything. So we are very appreciative to any type of treat that comes our way. So, you know, and like I said, we don't expect it or need it, but it is a very kind thing. You know, I've had patients like in the morning, like, well, you know, I guess they were stopping to pick up their Starbucks, so they picked up a random Starbucks for me too. And I was like, oh my God, that's so nice. Like, you just feel very appreciative towards the patients for them to actually think of you like a human being and somebody who would, you know, benefit from an extra coffee.
Yes. Yes. It's that you thought of me as a human being and not as your personal assistant and servant. That's what it is.
That's good to know, because I mostly often book my appointments like after lunch. You know, I typically might work in the morning. Lunch is kind of and I sometimes question, you know, is it good for, you know, are they in a good mood after lunch? I figured, you know, they've had like their energy revived.
You know, I think if you want more, for me, if you want more time, book my last appointment of the day, because I don't have something hanging over my head where I have to run. And so I can spend a couple minutes with you.
What about you, Dr. Ray?
I mean, my schedule and my day is always so unpredictable with the babies coming. So it's really hard to say. You know, I could say book the first appointment of the day, because then, you know, I've just gotten there and I've had, you know, usually I'll get there half an hour early and I've caught up on some notes and I'm sort of waiting and ready to start my day. And, you know, I don't have something that's already, you know, made me frustrated or, you know, tired already. So I would say book the first appointment, but very often, sometimes I'm on my way to the hospital and I get called to go do a delivery. And then I'm a half an hour, 45 minutes, an hour late to the office. And so then by the time I come in, then now because I'm behind, I'm going to feel a little pressured to get through the patients a little quicker. So it does change. So it really is very unpredictable from day to day. I have no idea whether I'm going to be on time all day. I have no idea whether I'm going to have deliveries interfere in my day. So every day it's just sort of, you take it as it comes. You know, I try and do my best to see the patients and be on time and be there for them. But when these babies come, they come, and they don't, you know, wait until my lunch break, or they don't wait until 5 p.m. So they do interfere in the schedule. So I think if you're going to see an OBGYN who actively delivers, then any time of day is just a gamble. You just hope and pray that, you know, there's the doctor's, there and on time and doesn't have to leave.
Just
And
bring
then there's
food.
free lunch. And then there's the issues with just a million other things of like the office and whether or not you've had to like wait. I've had a period of time where it took almost 6 months to get an appointment with me. So you're not going to be like, oh, I can't take that morning appointment. I want the last appointment of the day, because you might have to wait another month on top of that.
Mm-hmm.
So sometimes you just I wouldn't try to, I don't think that should make enough of a difference for you to schedule your life around that, if that makes any sense. Like, I would not pay much attention to that if you're scheduling to see your doctor.
Okay. SJ, you've got a comment.
Okay, so what I'm getting, if I'm tracking correctly, OB-GYNs, the best time to book them is usually in the morning, because the darn babies always mess with the schedule.
But middle of the week, just in case they have a 24-hour shift.
If it's a general practitioner, book the end of the day, because you'll get the best time slot.
Depends on the practitioner. See, that's just for me. But like, I'm willing to kill myself to give you a couple minutes if I can. But if I have to run and go pick up my kids from daycare or something, sorry, gotta go. So that's just for me. So it depends on, really, it's not enough one of those things where you should be worrying so much about when to schedule an appointment. Just make sure that you are scheduling them with the providers that you need. So, and if you need more time, we're happy to bring you back. It's like, hey, I can't fix everything right now, but we'll schedule you for a follow-up. So,
but
I guess I would say the most important thing.
Come back.
Yeah, I don't want to go back.
Well, okay, see, that's the kind of patient that I want to start to get upset with, because they come in, they don't, they want to pay their copay again, and now you want to talk about your shoulder pain, your neck pain, your abdominal pain, your rectal bleeding, your blurred vision, your this and that, plus your diabetes. Oh, why is your blood pressure so high? And you want to do that in 15 minutes.
I got you a muffin.
Wait, I gave you a muffin. Nicer to me.
It's appreciated. It's very much appreciated that you brought a muffin, but we only have so much time that we can give you. And so if you come in, especially for the PCPs, if you come in with 10 problems, you haven't been to the doctor in 2 years. Now you have a list of 10 problems that you want to spend the entire time talking about. There's just not enough time to get through those. So oftentimes the PCPs will say, okay, what is like the top 2 problems that you have right now that we can work on getting right now? And then for the other problems, I'll order some tests and I'll bring you back in a couple weeks, and then we can address those other problems. But medicine, we can't hear all of your problems and fix all of your problems all within one visit. Some of them require maybe some blood work to help us better understand the situation, or some radiology studies to better understand the situation. And then simply we just don't have enough time. Managing your asthma will take up all the time that maybe we have. Then you add on your high blood pressure and your diabetes and the fact that you just developed a rash, and because all this stuff. So we can't fix everything in that little amount of time. So don't come to the doctor expecting us to fix everything you have. What are your top priorities that need to be fixed right now? You have this rash that's really bothering you, and your asthma is getting worse. We can easily fix those in that visit. But then now we notice your blood pressure is high. Okay, maybe we need to bring you back and let's work on your blood pressure at the next visit, because we just simply don't have the time with the way corporate medicine has gone, the way the insurance reimbursement has gone. We simply do not have the time to fix everything in that 10 to 15 minutes slot that you're allowed.
Exactly. And then also what the patient expects to be, what they're most worried about is this. And I'm more worried about that, because that's more immediately life threatening. And so that's really a frustrating situation to be like, oh, hey, I know that you're really worried about whatever, but I got to address this, because this is the kind of stuff that can kill you. And then the other problem too.
I was going to say, the way I equivalate it to the patients is I tell them it's like taking your car to go get an oil change. If you call and say, I need an oil change, they're going to book you for maybe like a 1 hour slot with their mechanic, because it should just take an hour to do an oil change and that's it.
15 minutes.
But when So when you come in and you say, oh, I booked an oil change, but I also want to get new tires. I want to get the transmission fluid changed. I want to get,
Car wash.
rotation done. I want to get, an interior detailing done.
Yeah,
I
the
want
door
to
latch
get,
is broken and this and that.
the windows don't go down. The heated seats don't work. And I want you all to fix that today at the same visit because this is the time I took off from work to get all of this stuff done. The mechanic is going to say, we didn't book you into that time slot. All of those problems are going to take up an entire day of the mechanic's time. So we cannot do that. We will do your oil change today, which we agreed upon, and then we'll make you a follow-up visit to come back and do all of those other problems with your car. So when patients get upset, I try and use that analogy, and most of them understand it.
And the frustrating, that's a great analogy, but see, the frustrating thing is you've spent so much time discussing your analogy and getting to understand why you can't do it. Now this appointment's over. Right. Now I can't address anything.
Okay.
And so you're like, okay. And then I do firmly believe in the primary care arena. And I mean, I even feel this is true a lot for a lot of gynecology. It's when you're talking about menstrual histories and all that stuff. I could often tell you what the problem is or have strong suspicions based on what you're saying, And so I think a lot of the patient, I know how this sounds, but the patient will tell you what they have if you have the opportunity to have the discussion with them. So much of it is the history. And so to make things to be more effective, first of all, when people come in and go, I've got this list, that doesn't make me happy. I'm like, crap. I mean, I can see that you have 49 things written on it and we have 13 minutes to go. This isn't going to work, right? So being all proud of your list is not making me happy. What you should be able to do is prioritize that list. And then you should also be able to tell me what's on your list. Well, and then, okay, just what's on the list? A rash, a cough, what is on the list? Because that way I can triage what is the most dangerous and then we can triage what is the most important for you. But we need to, right, and then also be able to describe the problem. If you come in and you have a rash and you've had this rash for 6 years, that's a lot different than you've had this rash for 6 months versus where you've had this rash for 6 days. Those are very, very different things. And so, when you ask somebody how long you've had this rash, oh, I don't know, a while. Okay, how long has it been a while? Oh, I don't know. Well, grandma this, and then it started this, and then it rained, and then I got the rash. You're like, okay, when was that? And it's I've literally told patients, okay, for the 5th time, about how long have you had this rash? Yeah. And I'll tell them it's a lot different if you had it for 5 years versus 5 minutes. Can you help me understand?
So for patients,
I
be
get
buttoned
that all
up.
the time. I get that all the time from my patients. I'll be like, oh, so when did you place your IUD? Oh, when my son was born. I'm like, okay, when was that? How old? I don't know your son. I don't know how old he is. I just need to know how old the IUD is to see whether or not I have to replace it.
Yeah, you get these nonsensical answers.
Yeah.
Nonsensical. Yeah. And then the other thing is the whole EHR. EHRs do not talk to each other. Okay. Everybody in the general public needs to know that. And so a lot of large health systems use a dominant platform, but a lot of large health systems don't. And a lot of medium and small health systems absolutely do not. And so when you come in and you're a new patient and I'm clicking, clacking away, at my computer while we're talking and I'm putting in data and I'm looking at you while I'm trying to type, right? Thank God I can sometimes do that and most of the time I can't. And then, you're asking, well, how long have you had this? I don't know. Can't you see it in your system? And that's when I want to throw something at people. No.
Exactly.
I 100% cannot. And no, not without your signature.
We've got a hand raised here. Go on.
Okay, this question I think is for Dr. Ray. What's the name of your mechanic? Because I would love it if my mechanic would just work on the one thing I asked for instead of finding 100 other things they want me to spend on.
Well, and I think for patients, they're also on defense, I don't want to have to pay another copay and the parking and,
Yeah, but that's not my problem though. Mm-hmm. See, I remember, what, the best way I can describe it when patients start talking about that is this. I am also a patient. I am a provider and I am also a patient. So the things that the patients have to face, I also have to face. So if you don't think that I have any sympathy for that, you're wrong. I absolutely do. But we're working with what we have to work with. There's nothing I can do about that.
this is all dictated by the insurance companies, what your copay is, what your coinsurance is. This is your insurance company, your plan that you chose, and we don't have any say in that. We just know that we have a certain amount of resources, a certain amount of time that we can help you, and we're trying to help you the best we can. But, coming in with multiple issues, all expecting to be fixed at one time, that I don't think any industry works like that, where we can fix everything that's wrong with a situation in one visit.
Mm-hmm. Unless
Well,
you're getting paid by the hour.
I can give you an example. I had a patient who came in who had an appointment scheduled. It was, I think, like a new patient 30-minute visit or something, and was super duper late. Like, if the appointment was like, I'm just making this, but I don't remember. If the appointment was like 11 a.m., this person came in at like 11:20, and the appointment's over at 11:30. Fully expected to be seen. Like, fully expected to be seen. I've never met this person. I don't know anything about them. I don't know what their insurance is. But I happened to be sitting at my workstation, which was just around a little separation wall from reception. And so I hear everything that happens.
Ooh.
And so I'm working on other charts, and I hear this person like, okay, we're so sorry, we're going to have to reschedule you. The patient was fine with it, fully realized that they were late, and then like really late. I mean, really, by the time the patient gets, by the time the insurance card is copied and the medical assistant is taking you in the back to get your blood pressure and figure out what meds you're currently taking that you probably don't know, but you should have known because you're coming to the doctor who goes to the doctor not knowing what meds they take. I think that's weird. And, especially a new doctor, like, we don't know. How would I know what you're taking? I don't know you, at all. I've never met you. And comes in, all that stuff. It's going to be now 11:29. I have 1 minute to figure out what I need to do with you. I mean, honestly, like, that's absurd, right? So, and that makes me stressed because now I can't just ignore you. And then now I have to be late for my next patient, no matter how fast I work, even if I only spend 5 minutes with you, which is garbage. It's garbage. I'm still late for my next person. So when people say, well, my doctor's always running late, it's because of stuff like that. Okay. I'm not in the back having coffee, filing my nails, watching funny YouTube videos. Like, I am busy, So I'm sitting there working. I could hear this person talking, and the symptoms were described they're alarming. Like, well, I'm here because of this. And I'm like, oh, that potentially is extremely very serious. So I went up there and I interrupted the patient. Now, granted, it's now 11:22. My next appointment's at 11:30. I believe that patient was already in the room. And I said, hi, I'm going to interrupt. I'm Dr. Foz. Nice to meet you. Follow me. I took this person in the back of the exam room and I said, this is not going to be a visit, but what you had said up there made me alarmed. Like, I can't, in good conscience be like, you should just come back and hopefully find an appointment in the next 5 months or something. And I said, can you just give me a brief idea of this and that and the other? So what I'm going to go ahead and do is order some labs on you so you get those done. So at least we can get this started, right? I don't know your situation. I don't know your medical history, but what you said triggered me to do this. And this person was like, oh yeah. And then started to be like, and also my knee. And then also I was like, this person started like,
that's when you have to refer them to our podcast.
I was just like, okay. I can't, like, I even just told you, this is not I'm doing like a curbside thing for you, dude. I'm not diagnosing anything. I don't even know who you are. I barely know your name, and you have the audacity to continue to want more of my time. Like, you were just thinking we're doing the appointment, even though I told you we're not. And so that's the kind of stuff I deal with on a regular. That's not rare. It's not rare. This is not something that happened like, oh, this is like 6 years ago. This is stuff.
Right.
That's regular.
Well, and I get the same situation too. Like, I'll be in my office and I'll get called for a delivery. My phone will ring and say, we need you to come do a delivery. And I'll see, okay, maybe I have one patient in the room. And if I go do the delivery and come back, it's going to be minimum 45 minutes to an hour. So I feel bad that this person's going to be sitting there or potentially have to cancel. So I'll do a quick look and see what they're there for. And if it's something I think is fast, like if they're there just for their routine prenatal visit or maybe just a yeast infection, I'll try and see them before I leave. So I walk in and the first thing I say is, hi, I'm so sorry. I just got called for a delivery. I really don't want you to have to wait here for an hour for me to return. If we can do this visit quickly, then I can get you in and out, and then I'll go do my delivery. They always say yes, and then I expect them, because I just told them that, to just sort of tell, like, we're going to have a very limited, quick discussion. Okay, you're here for your prenatal visit. I ask them 4 or 5 questions, any problems, any of this. Okay, this is the lab test that you need to get done. I'll see you at your next visit. Thank you very much. Majority of the patients, probably 80% of them, will comply and understand and are thankful, because they don't want to sit there for an hour waiting for me to come back. They're just there for their routine checkup. They just want to get
It's an
things
hour.
checked, and
That's
that's
assuming
it.
everything goes
Maybe,
well.
oh, right, exactly. Or yes, you think you have a yeast infection. Okay, let me check. Yes, you do have a yeast infection. Here's your medication. If it doesn't work, come back. That's it. So these can be very simple, straightforward visits. But some of the time I say that exact thing, and they want to keep talking about something and bring up something else. And then they have questions about this and questions about that. And I know they can see from my face and my body language that I'm like, I'm like in a rush. Like I don't sit, I stand, for the visit. I don't make myself comfortable.
Wow.
And I'm thinking to myself, didn't I just tell you I have to leave? I'm doing you a favor. I'm trying to see you quickly. Your problem is something I can fix quickly. Why are you going on and talking about all this other stuff? I don't need to know this stuff. I cannot fix it. I need to finish, and sometimes I have to cut them off and say, you know what, I'm sorry. If this is going to go much longer, then I really do have to leave. Like I mentioned at the beginning, I have to go do a delivery. If you would like to continue this, I'll be back in an hour. And most of the time they're like, no, okay. Then they kind of just stop, and then that's it. And then I'm just like, okay, here's, this is a solution to the original problem you had. Sorry? Say that again?
And then they submit a complaint.
Oh, yes. Right. Exactly. Yeah.
Don't forget that icing on the cake.
Yeah. So if your doctor is in a rush, or they say to you flat out, I need to go do something else, I'm trying to accommodate you, or you don't have an appointment today, but I'm going to try and accommodate you and order at least something so that when you come back for your appointment, we will have some information. Please respect their time. They're going out of their way and doing something extra to help you so that you're not inconvenienced. But in return, please don't inconvenience them.
There you go. Be buttoned up, right? Prioritize your questions. And
know a little bit about what's been bugging you. Like one of the things that really helps is how long have you had this problem?
yeah.
And if you tell me it's been 6 years, like, okay, then my next question is what triggered you to come in today and not 6 months ago? And it's often a change in the situation. But for me to have to like drag that out of you is ridiculous.
Okay, we've got another hand raised here.
Okay, disclaimer. I watched The Pit. In either of your offices, are you using or plan to use AI for either dictation, charting, or in other areas?
I use AI for dictation, but not anywhere else.
There you go.
Is it accurate?
It is very accurate, but it doesn't, it sometimes doesn't decipher between what the patient is saying and what I'm saying. For example, what it is like an AI scribe. So basically, listens to the conversation and then prints out the conversation so that I can put that into my medical record. But
as a summary.
So if the patient, say I'm saying a pregnant patient, and she's like, oh, my back hurts, blah, blah, blah. And I said, oh yeah, it's probably sciatica. I had sciatica when I was pregnant with my twins, so I understand how that feels. What helped me was, using massage gun and heating pad and everything. And then when I look at the printout after I'm done, when I'm transcribing, when I'm putting it into my medical record, it'll say, patient complaining of sciatica because of her twin pregnancy, And I'm like, no, the patient doesn't have twins. I had twins, So then I have to, so then I go back and
always
I have
read
to correct
over.
that. Yeah. So I always have to read over it or something because, anything that if I say something about myself, or a situation or Sometimes the patient has their, like maybe their mother in the room with them, and the mother will say, well, she's having so much pain with her periods. Do you think she'll need a hysterectomy? Because I had a hysterectomy when I was 27 and because of the same reasons. And then in the history, it'll say patient had a hysterectomy at 27. So it doesn't fully like recognize different voice tones. So there is inaccuracies. So I definitely have to proofread everything.
That's good. And, speaking of schedules and time and respecting people's time, I know we have Dr. Ray that needs to, we'll have to leave sooner before we end this episode, this fun episode. I will want to bring up the insurance part that you started discussing. And the big news this week is, unfortunately for our generation, the passing of James Van Der Beek and this health insurance story around it.
Yeah.
What's, any comment about that?
I don't know anything about his health insurance situation, so I don't know. Should I know something about his health insurance?
Well, yeah, and long story short, you can come to AuntieDerek.com. We tell you all the celebrity tea over it. But
I rely on our host to do that. I'm so lost that the host fucking me. Oh, do you know so-and-so?
I don't think it's public. I don't think it's public knowledge what his insurance issues were or anything like that. But it is an interesting case for sure. I find myself going back and forth on what to think, but in the end, it seems to be a good man, a good father, a good partner who has now, passed away way too early from a terrible disease, and with 6 children now left fatherless, it's a very sad situation. So anything that anyone can do to make their lives better, I'm all for that. So
yeah, supposedly, again, we're just reading what's kind of on the news that their friends and family had to raise money because of the expensive cost of his health insurance, battling colon cancer since 2023. So
yep, it was a couple of years. He actually had to sell Dawson's Creek memorabilia to help pay for those cancer treatments.
Yeah, was he insured? That's
yeah,
my
question is, you pay a certain part and then the rest the insurance pays for that, right?
Well, it depends. Insurance is different depending on the source of your insurance, and I actually don't know as much about this anymore. I know that years and years and years ago, there used to be insurance caps. Like, if you had an insurance policy and you had like a $6 million lifetime cap, that'd be it. Like, if you had, like, they would stop covering you past that point. But that was also like pre 9/11 stuff. I don't know anymore. Like, I don't think that's really the case, but everybody's insurance is so wildly different. And I think that's what's really hard for people who are not Americans to fully understand. What is your monthly costs? What is your copay? What is your deductible? What is your drug insurance coverage? Like your drug deductible, that's separate from whatever deductible. Like, so, and then if you're hospitalized, this is what happens. And so it's very complicated. I don't even fully understand my own insurance, if that makes anybody feel better. It's a broken system. I think so. I think it's bad for us. I think it's, I have so many patients who are from outside the United States. They're here and then they're just like, this is scary because I could go bankrupt because of healthcare stuff or whatever. So I plan to go back to my home country of whatever that has socialized medicine when I get older or after I finish my stint here or whatever their situation is. But I don't know, like, was he not insured?
He was. Yep. It was just like, it wasn't covering all of what was needed.
It might also be the type of cancer treatments that he was doing. Sometimes, if the one treatments aren't working and they want to try something else, the something else is not covered. And he may have been, at the end a little bit more desperate to try something and went to try something that wasn't covered and tried to raise money for that with the hope that he would live longer.
Mm-hmm. Okay. Yeah, I
And then
didn't know
there's
about
care at
CAP.
the end of life, like end of life. Well, I don't think those, don't quote me on that. I don't know if those caps still apply. Because the last time I'd asked about that, which was a long time ago, they're like, no, that doesn't work anymore. I'm like, okay. But there's also the costs that are coming with like when somebody approaches the end of their life, like the care, like the custodial care that has to happen is difficult. Like they need somebody to help them bathe and dress and stay clean and be comfortable and to eat and just all those things that are just really difficult for an adult.
Yeah. Well, having experienced this recently with a family member, one thing I learned is if regarding hospice end of life, um, if you have insurance, you'll be covered by your insurance, and if you don't, there's actually kind of like a group that covers it. It's like a
Yes.
nonprofit group, right?
Yes,
And
hospice unlocks federal funding generally. My loose, please don't quote me. I don't know for sure. Understanding is when somebody's placed on hospice status, there's federal funds that are
yeah,
unlocked for that. I think it kicks in from like Medicare or something like that. So
yes,
that is a little bit different, but not everybody who needs custodial care is ready or able to be on hospice.
yeah. And if you have very very good insurance, expensive insurance, or a veteran, you get to have a nurse come in every day. Otherwise, you get, one RN a week and one nurse, to help, clean the patient up once a week. So that's
Wow.
something that I learned.
Veterans get that daily? That's great.
Yeah.
That's
So,
awesome.
don't marry a doctor, marry a, I'm just kidding.
I'm marrying a doctor.
The doctor's away for like 24 hours. I'm just kidding. All right.
Yeah, marry
We'll
a
trim
doctor
that out.
if you're happy living independently.
There you go.
Dr.
Are
Ray,
you,
do you have to go?
Yeah, I'm going to go ahead and sign off. So wish you luck on the rest of the podcast, and everyone have a nice Sunday.
Thank you,
You
Thank
Dr.
you. You
too.
Ray.
too.
We'll miss you. See you next time.
All right, so we'll continue this. We're talking about schedules. We're talking about when you go to the ER, when you go to urgent care. We're talking about insurance. Kind of change this topic a little bit. Let's talk about how do you test your blood pressure at home, and why do you need to do that?
Oh, I wish this could be a whole topic by itself.
We can make it a whole topic, but just
I
kind
think
of the
that,
basics.
that is my little blood pressure is my baby. There's a lot of lives that can be saved if hypertension is identified and managed appropriately. I think a lot more people would have healthier lives.
Well, maybe we could do that for the next episode then.
Yeah, I would love to do that. It's my personal interest.
I know.
One of my personal interests.
It's like I have to take CPR classes and blood pressure medication classes. How to test blood pressure.
Well, hypertension. Okay, here's the deal. Hypertension is a silent killer, and that's the problem. It's silent, right? And certain populations have more issues with it. And it leads to a lot of cardiovascular disease that could have been prevented or delayed if it's appropriately managed. But we can talk more about that.
Yeah, we'll talk about it in the next episode. I'll bring in another topic here. So, I was on a call with a friend, and, my friend got into an accident a week prior. And then during the call, she started feeling this pain on, upper left of her stomach. And then she goes, hold on, I just need to breathe, stay on the phone. And then here she started asking me, is that the spleen? And I was like, I have no idea where the spleen is.
Okay. Well, okay. How about this? High school anatomy. Maybe look at a book. This is what I call basic life understanding. I know how to add and multiply and subtract and divide. So the spleen is an organ that is a solid organ, and it lives in the left upper quadrant. So it's the left side. So This is not when you have somebody who has like the inversus, like Catherine O'Hara did, right? But in the normal adults, human, or the normal human, even babies, it's an organ on the left upper side of the abdomen, so kind of tucked, sort of just underneath the rib cage on the left side.
Okay. And you're so lucky I didn't call you. She's like, what do you think that is? It's like a really sharp pain. I said, hold on. Let me look it up in AI. Let me ask.
Okay. Well, one of the things to know about the internal organs, right? So the innervation. So how do we know, like if I pinched your finger, right? How do you know that I pinched your finger, right? There's nerves that send signals to your brain that tell you, hey, somebody just pinched your finger lightly. It was your ring finger on the left hand or whatever it is, right? Innervation, like that sensory innervation to the quote gut, right? So anything inside the abdominal or thoracic cavity is not as well delineated. So if I went in and could magically pinch somebody's like appendix, which is classically on the right lower side of the abdomen, you might actually feel it in your right shoulder.
Wow.
Theoretically, right? Or like, yeah, so that's a common thing. So like people who have like gallbladder issues, right? So gallstones classically present as like right upper quadrant pain, but they actually might not feel the pain in the right upper quadrant. So the kind of like what I was talking about the spleen, it's like kind of on the right upper side of the abdomen, just tucked underneath the ribs right there. They might feel it as like right shoulder pain or right back pain.
Left spleen, right? Left.
Spleen is left, gallbladder's right.
Yeah. Okay. Yeah. So that's what we were doing, and I was like, well, go on.
Well, but see, that's what I'm trying to say is, so the innervation isn't as specific. So when you have somebody who has like left upper quadrant pain, that could be something splenic. It could also be the colon. It could also be musculoskeletal. It could be the heart. It could be the like stomach itself. So the location gives us a clue, but sometimes you have to think outside the box.
Wow. Yeah, I mean,
because of that innervation, right? So it's not as specific. The sensory innervation isn't as delineated as to things on the outside of the body.
Yeah. And, that's why I was like, okay, I think you're going to need to go to the ER. Is anyone there with you at home? Because no one's with me. And so I'm just like, okay, is the pain hurting again? And I'm reading this AI stuff, and I'm just like,
do I know this person?
You may, and I said, and one of the things is, well, if you got into an accident, of course, like they said, it could be a ruptured, spleen, and it's a bleeding. And then
what are the, hold on, okay, wait. Can you give me the initials of who this person was?
No, I can't give you the initials.
Okay. We'll
but
talk later.
I tell AI, well, the accident was like, a week ago. And then AI goes, well, if it's been a week ago, that's a different, relax and rest. And I'm just like, okay, if it comes back, then you need to go to the ER. And again, it's one of those things, like, do you go to the ER? Do you not go to the ER?
Well, if you think you ruptured your spleen, that's definitely in the realm of the ER. Do not go to urgent care for that one.
And the whole time I'm just like, just remember, I am not a doctor. I just host one. I said, if you're okay, you could come to the podcast tomorrow. Go ahead, Auntie.
So I had like I had a question about because you were bringing up signals early, like your body sends you signals, and just out of curiosity, have you? Because I know you were big on blood pressure and hypertension. Have you heard of Rosie O'Donnell's HEP acronym, like HEP acronym, which I love. Okay, so
I rely on you and our host to keep me informed as to pop culture things like this because I just don't follow it. So
yeah, I have to text her like, did you know that?
Well, I think you're going to love this. So HEP, so it's HEPPP. Rosie O'Donnell actually said that that saved her from having a heart attack. And she said, so it stands for, the H stands for, hot, like if you're really hot, hotter than you've ever been. The E stands for exhausted. And then she says, the P stands for pain, like if you're having chest or arm pain. She says, if you're, the other P stands for pale. And then, like if your body's turning pale, and then finally, the final P stands for puke. Once you have, thrown up, then that's alarming. Then you need to really see what's up because, and she said that saved her life because her doctor told her she was having a heart attack.
Those are, especially in women do not necessarily have the classic symptoms of heart disease. So they'll have more like nausea and dizziness as opposed to just like crushing substernal chest pain. But truthfully, a lot of those things I know how this sounds. I'm not trying to dissuade people from paying attention to that. So please, I hear you. But also like those can be symptoms of other things in somebody who doesn't have risk factors. And so that's the problem with, I think, medicine. The way to understand it is not everything applies to everybody at all times. So if that were to happen to like a 21-year-old marathon runner, for example, probably not a heart attack. Right?
Okay.
So it's often about, so medicine does not have the accuracy, sensitive, I don't really know, that I think would, like everybody thinks that I have a test for everything, right? So if you come in and I check your electrolytes in your blood and your sodium is low, let's say, for example, you need to eat more salt. That's not how that works. The sodium that in your diet has little to do with the blood sodium that I measure. The dietary stuff is not a measurable thing, if that makes any sense. I mean, yes, it does, but it's a very convoluted discussion that's wildly boring and beyond the scope of this discussion. But a lot of things come down to pre-test probability is probably how I would describe this. So it's if your statistical chances of having something are so low because, you have no risk factors and nothing like that, then the chances, so somebody having chest pain and feeling anxious and sweaty and you could also be having a panic attack, right? And so I don't want everybody to say, I'm having the symptoms, therefore I'm having a panic attack. Absolutely not. It's my job as a physician, if you come in with those things, is I have to figure out what might kill you right now. Like, okay, is this deadly right now? And so that's why, going back to my call of like, hey, you should probably go to the emergency room. You should probably go. But it's not, it's all about the probability of that. Now, from what I understand, Rosie O'Donnell is not young, and I don't imagine these things happened when she was 22. And so I don't know her medical history. Is she diabetic? Does she have hypertension? Does she have a family history of all these things that would also make that more likely? Everybody used to smoke. Did she smoke or does she smoke? I mean, there's all these things, right, that I don't know.
Right. So, and I think this message was geared towards like women of a certain age also.
Yeah, totally. And then, but also it's also not specific. I guess a lot of things are not specific. I mean, there are things in medicine that are very clear, very obvious. And then there are things that are like, well, we don't know, but the probability is this. And so now I have to do more evaluations to do this. Mm-hmm. And, but yeah, that's a good thing. So I guess the message is also women with heart disease don't always have classic symptoms.
Gotcha. That is good to know. Thank you.
I mean, what I learned from this podcast, what I learned from you is every health is individualized. That's what I tell them now.
Yeah. In your online practice?
In my online practice, that's what I tell my patients, that it's individualized. So,
Estee, are you hearing this?
That sounds very scary.
But yeah, I mean, it's, and that's why there isn't, and yeah, you just gotta work with your doctor, have some trust, and be prepared, know your story, have some patience. Everybody, I will work with anybody as long as you just give me a chance.
Yeah, I think yesterday's scenario is why I brought up, these questions, because, here I am talking to someone over the phone and kind of like, at what point is this an emergency? And I'm kind of like prepared to, I'm going to have to call 911. At what point do I look it up?
Okay. So general things is if somebody, you can so you have to be careful because you called 911 and now you have a bill, and that I shouldn't have to say that. Like I shouldn't have to, healthcare is not luxury. It's a human right. But I also understand why insurances do this in some ways because of abuse, right? You have patients who are like, oh, I have no deductible. I'm going to call my doctor every day because I don't feel good. I just don't feel good. I'm here again. Okay, well, what is it today? And it's just somebody who has psychiatric needs or is lonely or a hypochondriac or whatever the situation is. And if you have something that's very severe, like severe uncontrollable pain, I don't care what it is, go to the emergency room. Just go. Like, I can't live with this pain. Go to the ER. Like, we can figure out what's causing it or come up with some sort of plan, or do we need to admit you to the hospital for pain control or whatever, right? If you have some sort of bleeding that's not stopping, you should probably go to the emergency room. There's a saying in medicine that's basically all bleeding stops at some point. So, but we want to get you to, if you're having a period that just won't quit and I'm hemorrhaging, you should go to the emergency room. If you cut yourself and it will not stop bleeding, or you have a nosebleed that just will not stop bleeding, you should go to the emergency room because maybe there's something that needs to be done.
Has there ever been a case where like a person just never stops pooping?
What?
I don't know. I'll trim this out.
Yeah, like uncontrollable diarrhea. I'm sure that I can tell you a story back in 2005.
There is something called cholera, which is an infectious disease problem. It's bacteria, and it causes a severe intestinal infection that is a huge cause of death, particularly in young kids in other parts of the world where sanitation may not be so well developed. And it causes a diarrhea that's, it's basically this massive diarrhea. It's not just like trying to get it out. Your intestines just kind of continually put out more and more fluids that have to come out. And then you basically die of dehydration. So yes, you can poop until you die.
Wow. Okay.
Yeah.
Well, we have
Let's
many.
hope that I don't have to deal with that in my patient. I'm like a domestic cat when it comes to medicine, right? Like I don't see cholera a lot. Let's put it that way.
Well, I have more questions before we close this episode. How do you know if you are lactose intolerant?
Probably the simplest thing for anybody is if you remove all dairy from your diet and your symptoms go away, and then you reintroduce the diet, you introduce dairy and it gives you an upset stomach, then that's it. Most non-Caucasian adults will be lactose intolerant. And I think even most, yeah, so it is related to like historical like exposure to lactose, and which is dairy, right? So if you're from a culture that did not classically have dairy as part of the diet, then you may have more issues. But even patients who are not, quote, lactose intolerant, if you give them enough lactose, I think most adults will have some sort of problem. It just might be significant. So what it is lactose is sugar that's naturally occurring in dairy. And it is a sugar that in certain populations, you don't have the enzyme in your intestinal wall to digest that sugar. And so when you can't digest that sugar, it then feeds, what it basically does is it sort of ferments, but really it acts as an osmotic laxative. So basically there's all this stuff that would normally be broken down in your intestines that makes it to your lower part of your digestion, and it pulls a lot of water in with it. And so it causes gas and cramping and runny stools. And that will go away once the lactose passes through. So you have a glass of milk, now you have an upset stomach, but then you poop it out and you gas it all out, and now it's out of your system in a day or two, you're back to normal. So the way to get around that is to avoid lactose. That's why they make like lactose-free milk and dairy products. Or you can try lactase tablets, which is the enzyme that kind of replaces that enzyme, and you can take that whenever you expect to have dairy. It is extremely common.
So I know some guys that like every time they eat pizza or burrito, Mexican food has cheese, and they go to the bathroom afterwards, and I'm just like, I think you're lactose intolerant, and they're just like, no, I'm
It's
not.
not a, it's not an allergy. It's something to understand. It's just that it's an inability to digest milk sugars because of that genetic thing, right?
Okay.
It's a genetic thing. And
So,
then
uh,
there's other people who have, so lactose intolerance is really common, but if you're eating food that doesn't have dairy in it, or you eat dairy in other capacities and they don't have any issue, then that would not be it, right? And then there's something called irritable bowel, which is extremely common. Irritable bowel is a complex diagnosis with complex findings that is, has a lot of theories behind it, but it often presents as people who have like abdominal pain and cramping that is relieved by, they have a meal and it is relieved by pooping.
Okay. Wow. We're going to go there. We're going to go there in future episodes.
Well, hold on. So just the thing is, though, is the way to know is if they still have that and there's absolutely no dairy in anything, then that's not lactose intolerance. If like all you're eating is like bananas and oranges and you still have that problem, then you don't have lactose intolerance. Does that make sense?
Yeah. Yeah. I mean, for me, it's like when I see, like pizza bathroom, burrito bathroom. It's like, milkshake bathroom. And I'm just like, you may need to see your doctor. You may, according to my
there's
practice.
pizzas that don't have cheese, and there's also burritos that you can say, hey, hold the cheese, and what else would be dairy? It's sour cream, right?
Oh no, their food has a lot of dairy, and that's why,
Or the other thing is try a lactase pill when you eat those and see if it makes a difference.
And speaking of that, at what point, when do you eat the lactate pills? What's the...
I think you're supposed to take it just like just before you start, like if you're going to eat a piece of cheesecake or something, like take your lactase pill and then go ahead and eat. Like you don't want to take it like hours beforehand and you don't want to take it afterwards.
There you go. And how many lactate pills can you eat in a day without stuffing you up? The opposite,
I would suggest following the directions on the bottle.
There you go. All right. And that concludes this episode.
You should not exceed recommended doses of anything unless you have explicit instructions from your personal physician and not a podcast.
Well, I have people that they just love, like, hey, let's have, let's have a shake, let's have a cheeseburger. I'm just like, oh, don't worry, I got lactate pills. I just keep popping it. It's like, wait a minute.
Well, but the thing is like if it's as long as you're following directions, it's not likely to be an issue. I mean, you can overdose on anything, right? Even a bottle of salt, if you ate the whole thing, you'd be in trouble. But I mean, the truth of the matter is, as long as you know you're lactose intolerant and are willing to deal with it, then it's not, and somebody who's young and healthy who doesn't have like other stuff like kidney failure or dehydration is going to be a risk or something. I mean, it's not going to kill you.
Okay. Yeah, I have friends that they carry their lactate pill in their wallet. It's like their condom.
A lot of people do.
Mm-hmm.
Yeah, a lot of people do. And that's okay.
Yeah. Don't be ashamed. All right.